Hi. Hopefully I'm recording here. I'm gonna see, stop recording. So I guess I am recording. So we will go ahead, pause recording. Okay, I think I am recording. So we'll go ahead and we will take a look at what we talked about yesterday as a review for you to kind of look at. Again, we don't quiz over chapters 1, 2, 3, and 4, but I may have one or two questions on the final regarding what's in 1, 2, 3, and 4. And you'll get a study guide for the final. So, they call it a blueprint. You'll get a blueprint for the final. So let's just jump right in here. Oh, oops, sorry. I don't know what that is. Well, that's doing that. Go away. Okay. Oh, okay. I don't know what I'm doing, evidently. All right, so let's share. And we're gonna share. I think this is one. We're gonna share one so you guys can look at it as I'm talking about it. Okay. And okay. Don't know why it's doing that. But we're gonna go ahead and open everything up. All right, there we go. Here we go. So I'm gonna move myself over here so you don't have to look at me. So we're gonna talk about chapter 1, the foundations. Again, we're gonna go through this. Mental health. Again, there's no one universal definition. It depends on the person, depends on your relationships, it depends on your environments. So, we talked culturally, how different cultures have a different aspect or a different look at mental health and mental illness. And we'll get into a few of those later on in chapters 3 and 4, I believe. Mental illness includes problems with mood, behavior, and thinking. The examples I gave in class were mood being bipolar disorder or depression. Behavior could be erratic behavior related to mania or related to schizophrenia, and then the delusional thinking that accompanies some psychotic disorders. When it interferes with your normal ADLs, that's when it is actually considered diagnosable as a mental illness. Um, Again, it depends on the individual, which has a lot to do with genetics. And I shared there's a lot of genetic disorders that are familial traits in mental illness, including schizophrenia. That's a big one. Mania, that's a big one. They actually have found the genetic mutations that cause that. Interpersonal, there's some personality disorders that have trouble communicating. Schizotypical, schizophrenic, schizoaffective. Um, we'll talk about those later on, so don't worry about them. And then people who just, do not have adequate support, depending on the environment that they're in or depending upon the situation, be it like an abusive relationship. And then society tells us what's normal. In the United States, what's considered normal is considered to be mentally healthy. And then any aberrations of that are mental illness. Some different things. Some people just are negative. Um, Though we call those people dysthymic, and it is a personality disorder. So, and then some people have discrimination against them or believe specific things. Mental illness having a huge stigma related to negativity. People are afraid of those with mental illness in some instances. And that's, it may be warranted, it may be created in their mind because of observation of bizarre behaviors, but it just depends. Um, the DSM-5, you probably ought to know this. The DSM-5 is a book. It's a DSM-5 TR right now because it's going through a transitional period. We're about to have the DSM-6. It is coming, it's not out yet. And I never buy any TR versions just because I know that's the transitional version. So, but I do have a DSM-5 that I will bring to class so you guys can see it. You pass it around and kind of put your hands on it and flip through it if you want to. But it gives us a common language that practitioner nurses can use when describing someone with mental health issues. It gives us some of the defining characteristics or the diagnostic criteria. I believe schizophrenia, you have to have some of the positive symptoms, delusions, hallucinations, primarily for at least 1 month, pervasive and invasive thoughts for up to 6 months or something like that. We can look it up when I get the DSM-5 to class, and then you're welcome to kind of peruse that. And sometimes it helps us understanding the underlying cause. But again, with some of these disease processes, like with their medications that treat them, what you'll see is the common statement, this is what they think causes this. And mainly that's because we can't measure the neurotransmitters inside the brain, but we can see them on like PET scans and SPECT scans and things like that. And you can see a wonderful brain that is depressed or healthy, and you see all this pink and green, showing the different neurotransmitters as radioisotopes tracers that show the neurotransmitters into action. And then you see a person with a depressed brain, and there's nothing there. It's just blue, showing a lack of the neurotransmitters. So, because we can see them, we know that those neurotransmitters are what we need to have a healthy brain. We don't know how much of it. We don't know anything like that, but we do know that we need them to be present. But we'll talk about that when we get into specific disease processes. Like I mentioned in class, when you're talking about schizophrenia, you're mainly focusing on dopamine. And when you're talking about depression, you're looking at norepinephrine and serotonin. There's particular ones that go with particular disease processes. So, but we'll get there. Okay, DSM-5, I'm going to show you the book. It helps identify the factors related to the condition. This is a change from our previous classification system, which was an axis system. So don't even worry about that. Doesn't exist anymore. Just know these three things that are included in the classification for DSM-5. The major psychopathy or psychiatric disorder, any medical conditions that are contributory or could be contributory, but have been ruled out, and then any kind of psychosocial and environmental problems. So what you may see in a patient's chart is they've been admitted with bipolar cyclic, which or bipolar cyclothymic, which means they're a rapid cycler between mania and depression. They also have diabetes mellitus, and then they have a limited support system because family lives in Florida, or they are unhoused, they're homeless. So you'll see these three things being adjusted in classifications depending upon the person's individual situation. Okay, so the mental health is not standardized, so this is false. Okay. A long time ago, ancient times, the sickness was the displeasure of the gods. They kind of looked at it as being demonic possession. Um, Aristotle, he talked about the four humors, balancing them. We could purge somebody, they could vomit, they could starve, we could put leeches on them, get blood, just to get all the bad juju or the bad thoughts out of their head. What was believed. Christians early on thought it was possession by demons, and then later on, it was not just possession by demons, but actual demons that were present and alive. I'm not going to ask you that. I'm not going to ask you to differentiate between that, so don't worry about that. Just, a little history where we know where we were. In the 1790s, we had the creation of asylums over in England, and then Dorothea Dix brought those to the United States. And it basically was just a housing opportunity for the mentally ill who were kind of roaming the countryside. At least they were safe in these places, but at the same time, they weren't fed, they weren't protected from each other. It was kind of an ugly time. Freud, he said, hey, guess what? We need to study these people. We need to figure out what makes them tick, and why they are not working the way they're working or need to be working for society's sake. So he was the first one to start studies. In the 50s, 1950s, we got some drugs, mainly Thorazine and lithium. But there's a whole bunch of other ones. In the 50s and 60s, we had deinstitutionalization, which people in the asylums were released back out into the communities, which was unfortunate because then they would decompensate because we didn't send them out there with any meds. Um, they would decompensate, they were a danger to themselves or others. Then they would go into the hospital because of something that they did to themselves or somebody else. The hospital would say, okay, we're going to keep you here for a couple days and we're going to send you out maybe with a week of meds, and then you don't have any more meds. And then it happens again and again, and they decompensate and they come back in. It's called the revolving door effect. It happened in the 50s and 60s. In the 50s and 60s, we also had legislation for disability income. So people started being able to get a check or get support for having a mental illness. And actually, in the 50s and 60s, we had the commitment laws change. So you just couldn't commit your neighbor for being a communist anymore. Or you couldn't do that. You had to have legitimate concerns about behaviors and things, danger to self and others being one of the biggest ones. Currently, we have 51.5 million adults and 23 million receiving treatment. So that's really an underserved population. 11 million children and adolescents. And that economic burden is greater than all types of cancer. Unfortunately, mental illness is not as well regarded as a true illness for insurance purposes and things like that. Leading cause of disability, and 1 in 4 adults and 1 in 5 children are treated. So 25%, 20% are getting treated, which is much less than need to be treated. Our populations, special populations that are the most undertreated are the homeless and those with substance abuse problems or prisoners. That's another population, I guess. We already talked about the revolving door effect due to deinstitutionalization. Here in the 2000s, we see a lot of boarding in the emergency rooms. You see them in special behavior rooms, and they're kept, however many days they're fed and all of that good stuff taken care of. But until we can get them into someplace that's inpatient for treatment and care, they're just kind of kept lingering in the emergency rooms. Um, it's unfortunate. We don't have more places for people to be housed for their own care, um, or at least taken someplace where they can be taken care of. We don't have a lot of long-term facilities at all anymore. Most of it's outpatient, which is okay. I mean, we can do a lot of good in the outpatient arena, but at the same time, we don't have a lot of outpatient arena, a lot of outpatient facilities around this area. I think somebody said yesterday Pathways is one. Coleman here in Lima is one, but that's more crisis housing. They are expanding it. They're building on the back of it for more um, longer term housing. I wouldn't say it's going to be forever, but maybe more than 3 day housing. Oh yeah, the one we heard about in Delphus from class, that new one over there, Westwood. I was excited to hear about that one, so I'm glad that we're starting to get some outpatient in more rural areas. So it's just kind of where we need it. So very good. Um, okay, so we talked about the hot shoulder hospital stays, the decompensation, and the rehospitalization, which is a revolving door. And usually it's substance abuse that's or usually it's mental illness that pushes to substance abuse as maladaptive coping. And then the dual diagnosis or the two of them together are usually the primary reasons for rehospitalization. So it's either someone has a um, manic episode where they are going out and they beat up the principal of the school or whatever. And, they spend tens of thousands of dollars on QVC and, they're also using cocaine or whatever and they overdose and they end up in the hospital for the overdose. And then it was discovered that they are manic. So, they're treated for the overdose on the medical floor and then they're put into the units for treatment for the mania. And either they are well managed and, linked to an outside resource where they're taken care of for both disorders, or they don't follow up and they end up back in the hospital. So it really depends on the person. I guess I just in class, we can't make anybody do anything, obviously. The patient has to want to be better. And if they don't see their disorder as being a problem, they're not going to seek treatment to be better. Issues and concerns, homelessness. About a third of those have some sort of chronic substance use disorder with a mental illness or dual diagnosis. And we, like I said, don't have a lot of community resources. Statement reflects the current state. We all agreed that it was A yesterday. Mental health costs exceed the cost for cancer care, which is true. And Healthy People 2030, that's just kind of a plan put out by, I think it's the NLN, that they have for the United States as a community. They wanted to reduce suicide rates, increase the proportion of children and adolescents who get treatment, not just identification anymore, reduce the populations of persons who experience depressive episodes, increase the proportion of adults with mental health disorders who have received treatment, and increase the number of homeless adults with mental health problems who receive treatment. Unfortunately, we don't have a lot of health centers. I've said it several times now. We don't have qualified people to be in those centers. We don't, I don't think community at a greater look understand the massive problem we have with mental illness. So the extent of the disease, I think that's what keeps the funding from being allocated to community centers, which we do need more of. Again, outpatient's much better than inpatient, because it allows people to stay in the communities. At least that's pervasive thought. And I don't know that it's wrong if they have a good support system or one who can be developed for that person, and if that person indeed does follow up and follow through with the treatments that they want. We all understood about managed care. We was kind of young, but managed care came in and gave us like a number of days that the insurance companies were willing to pay for treatment and service. It all came about in the 90s with utilization reviews and managed care organizations with the case management. And as far as mental health, it's not a highly billable disorder. So unless they come in with a not pre-existing, with an overdose or something like that, that they're treated on the medical floor for, you're not going to get as many days, or you're going to get a shorter, less money cap for the stay that they have in hospitals. So unfortunately, a lot of that separated mental health care from physical care for insurance coverage. The good news is that privately owned firms, greater than 36 people, they were allowed to institute their own in-house treatment. And then, of course, federally, we got Medicare and Medicaid that are paying for mental health services, which is wonderful. Mental health parity insurance coverage came about in the 2000s, saying that the level of treatment that somebody has for depression should be on the same spectrum as someone coming in with a similar physical problem. So maybe they try to kill themselves. So that's called mental health parity. Whether it's enacted or not, I don't know, but it's supposed to be. We all know we live in a culturally diverse population, and we all know that these days the identification of what's a family has changed. I mean, I'm raising my niece and my nephew; they're my children, because my sister's gone. So I'm their guardian, and they like to tell everybody their last name is my last name, even though I've not officially adopted them. But they are still, I call them my children. So that idea of a family, I think, is broadened over the years, and it's a good thing. So let's see. True or false? Community-based programs are preferable to treating people with mental illness. I said that is currently the thought, so that is true. We want them in the communities as long as they have a support system and as long as they are able to be followed through or followed up with for their mental illnesses. It's a good thing. Trivia. Linda Richard, first American psychiatric nurse. Massachusetts had the first site for training of nurses to work with persons with mental illness. And then we had extension of treatment for somatic therapies, including like electroconvulsive therapies and things like that. The first textbook was 1920. Johns Hopkins was the first school of nursing to include a nursing course in 13. So that school of nursing came out first before the first textbook. And the NLN said that all schools of nursing had to include an experience in psychiatric nursing. Hildegard Peplau and Jay Mello, they kind of said the same thing, but we here at Rhodes, we aspire and believe in Hildegard Peplau, who developed the therapeutic nurse-client relationship, looking at therapeutic communication, which is big. And we'll talk about that in a little bit. There is, of course, the American Nurses Association Standards of Care and Standards of Professional Performance. The psychiatric mental health nursing phenomena of concern are in that box. I can tell you their transference, countertransference, and resistance. Look at those. Sometimes those questions like that end up on our final. Like I'll tell you, I'll give you a situation. So you have a patient who elicits its feelings regarding something personal within the nurse. What is that called? Well, that's countertransference. Like you take care of a patient and he reminds you of your abusive boyfriend or whatever, you know. So that would be countertransference. Or my favorite, you're taking care of a teenager and they look at you and they say, "You sound just like my mom." That's transference. They're taking something they know and they're putting it on you. And then resistance, just about every patient experiences resistance. They don't want to talk about their problem, so they won't. And those are three phenomena of concern that we usually have to overcome. But you can look in the box. I'm hoping that I did find two texts that I'll bring to class next week, and I'm hoping that some of you are able to get some access to the text that the syllabus says is required. Like I said, 8th edition's fine, doesn't have to be the 9th edition. I probably wouldn't go back any further than that because 8th edition's from 2013. So we want to keep current, but in review, the two texts really don't have too much of a difference between them, between the 8th and the 9th, and they're probably getting ready to actually go to a 10th. But anyway, so. Nurses, different levels of nurses have different levels of abilities. You guys know that. You're being trained at the basic level right now. So you can do counseling. ADNs can do counseling. You can support melotherapy and self-care activities, psychobiologic interventions. You can give psych meds. You can do home teaching or case management and a lot of health promotion. Advanced level, it's the advanced practice nurse. Of course, they can do consultations, evaluations, clinical supervision, and prescribe drugs. Okay, that one really we talked about a little bit. It really doesn't apply to you guys. So just be aware, if you're a mental health nurse, you'll know. You'll know this is for you. If it affects the way you think or believe or you have trouble with an attitude taking care of somebody who has addictions, that was always my stick, was that, they did this to themselves. Well, you're gonna find out when we talk about the addictions in the addictions chapter, their only choice was the first time. After that, their brain chemistry changes and they no longer have a choice to use or not use. Be true to yourself, be who you think you are. Not a lot of people enjoy psychiatric nursing. It's not for everybody. But if you really do enjoy it, then go ahead and pursue it. It's always a good thing. So NLN required schools to include psychiatric nursing experiencing before the first nursing school included a psychiatric nursing course in its curriculum. I think that was true. Oh, that was false. Johns Hopkins, 1913, and NL came out in 1950. Okay. Oh, there's chapter one. Done. Remember, you can go back and forth with these. I'm going to move myself again. You can go back and forth with these. Okay. Now I want to go jump over to chapter two. Oh, but I'm going wrong. That one? Yeah, there we go. And then we're going to talk about chapter two. I believe I'm still screen sharing because I'm still up here in this little corner. And we're going to go right into chapter two from the beginning. And I hope you're reading along in the book along with this. So I hope it makes sense to you. So neurobiologic theories and psychopharmacology. And remember, I told you in class that this is very general. When we get into specific disease processes, when we're talking about those, I'll mention the medications that you really ought to know for those disease processes. Okay. Okay, so chapter two, we talked yesterday about the brain, just basic A&P overview, the cerebrum, cerebellum, brainstem, and limbic system, which is really where your mental illness happens. It happens whole brain, but their responses and reactions come from their limbic system. And then we talk about the neurotransmitters too. We have the cerebrum, which has two hemispheres and four lobes, frontal, parietal, temporal, and occipital. And there's the things that they're responsible for. We did talk in class about the frontal lobe being the one primarily blamed for the higher executive dysfunction and schizophrenia. But as you can see, you're going to have your emotional thing or your sense things, smell, taste, sight, all affected, causing hallucinations. So it's a whole brain disease. Below, we have the cerebellum, and it is coordinates movement and posture and reception integration of information from all body areas to coordinate movement and posture, also known as proprioception, or where we're known to be in time and space. So in other words, you're standing up, your eyes are closed, you don't fall down, you're standing up. You stay standing up, you can tell somebody you're standing up because you understand that. Or you're seated, you know you're seated. You close your eyes, you don't have to, say, hey, I don't know where I'm at. I'm sitting in a chair. I know that. That's because of your cerebellum. The brainstem, it has the midbrain, the pons, medulla oblongata, and then it is the nuclei for cranial nerves 3 through 12, and the locus coeruleus, which is where we get our fight or flight from. And then above the brainstem, we have the limbic system, and that's the thalamus, hypothalamus, hippocampus, and amygdala. All right, neurotransmitters. These are the guys that are really important in mental health and illness. We can't measure them inside the brain, but we can see them. We need to know they have to be in the right portions to relay messages. And then they play a role in medications. It's how we know medications are working. I talked about that brain that was red and orange in the normal brain, and then the depressed brain being blue with no red or orange. And then we give them a medication that gives them norepinephrine and serotonin. And we see the brain after that, and we see the red and orange again. That's how we know the medication works. Okay. We have the excitatory neurotransmitters, dopamine, norepinephrine, epinephrine, and glutamate. And we'll talk about those when we get to the disease processes they go with. And then the inhibitory ones, serotonin, sorry, GABA, or the one that can go either way, which is acetylcholine. Then we have some neuromodulators, histamine and neuropeptides. There are very few psych medications that work histamine-wise. So cerebellum has 4 lobes, yes or no, true or false. Now remember, this was the tricky one yesterday. It's false. The cerebrum has 4 lobes. Am I going to ask something like a test question? Somebody asked you this in AMP. So probably not, but good idea to kind of refresh your brain. We have the CT, the MRI, the PET scan, and the SPECT scan. The SPECT scan is the one where you can see actually the neurofibrillary tangles and plaques and tangles in Alzheimer's disease. The PET scan is where you can see all the neurotransmitters running around. The MRI, the CT, they're going to show changes in ventricles of the brain and the fissures and things like that. Just remember, they're radioactive, they're expensive, so we don't use them willy-nilly in mental health. Again, there are some that are genetic. We have done twin studies, adoption studies, family studies to see if it's nature versus nurture, and we have found that it is most commonly nature. Psychoimmunology and infections are some theories they think that possibly can cause some genetic at-risk populations to develop mental illnesses. I think it was the in utero study of pregnant women with German measles. They had German measles while they were pregnant, and they found that once the baby delivered later in life, the child developed schizophrenia. So that was kind of pervasive back in the 70s. I've not seen any follow-up studies regarding that. If you find any, let me know. Our role in research. Nurses are good researchers because we are on the front lines. We see things that are happening. We see trends. So it's our responsibility to help distinguish between facts and hypotheses and to make sure that families understand the disease process, looking for new research all the time or doing research ourselves, which sometimes you can do as a RN if you're invited to be part of a study. You can do data collection for someone who has an MSN or even a doctorate who's studying the actual particulars of, medications that are influenced. I think I talked a little bit in class about the Lovenox study and the genetic implications with that. So you could be involved in that kind of thing and answer questions if patients have questions. So you really need to be an educated person yourself. So is the following statement true or false? SPECT scans are considered the best type of brain imaging. Well, they're very expensive, I can tell you that. So it is false. It's not the best. Actually, you get up, you start with the MRI, or you start with the CT, then you go to the MRI, then you go to the PET, then you go to the SPECT, just the order I had it in. For insurance purposes, that's how they expect you to roll. So changes in the physicality of the brain are considered better diagnostic tools in the beginning. When you don't see any changes, you can justify going to those higher levels, such as the PET and the SPECT scans. And sometimes you just have to work your way up that way to actually see diagnostic material for the purposes of diagnostics. But there are other ways. Your vision, you're looking at somebody, you see their behaviors and how they're reacting, and you consult the DSM-5 and you say, gosh, they look like this person. And they look like they have all these diagnostic criteria. Now, as nurses, we don't diagnose, but you can have it in your mind. And then when the doctor comes out and says, yes, you're right, or yes, this person has this, you can say, ha, I recognize that. So anyway, I'm way off on a tangent. Let's go back. Drugs, psychotropic drugs. There's a lot of them. And again, this is general, so we'll talk specifics when we get to the disease processes. So some words you need to learn: the efficacy, which is maximal therapeutic effect, the potency. It shows you the difference between why, maybe 650 of Tylenol and 2 milligrams of morphine. The potency of it is different. They could kind of take care of pain, both of them, but you need 650 of this one versus 2 of this one in order to get the same effect. That's its potency. The half-life is how long it takes for half the drug to be excreted from the body. And then the FDA regulates all of our medications. They do not regulate herbs. So be sure to ask about herbal preparations of your patient because some herbal preparations will actually interfere with our psychotropics. Off-label therapy, we kind of talked a little bit about that yesterday. Primarily, the biggest off-label therapy is going to be in mania, where they might use an anticonvulsant to control the mania versus lithium, which is the gold standard, primarily in pregnancy because lithium is dangerous to the baby. That's an off-label use. And then we all talked about black box warnings and things that can happen. A lot of your psychotropics in the elderly, especially the neuroleptics or the antipsychotics, first and second generation can actually be cause sudden death from QT prolongation in the elderly. Sometimes you can get congestive failure from some of your other antidepressant medications. So they have black box warnings not to use in specific populations. The principles of psychopharmacology is we want to treat the symptoms. So if somebody's manic, we want to make sure that we can control that norepinephrine, epinephrine balance with serotonin or acetylcholine. Epinephrine, norepinephrine is the high and the serotonin is the inhibitory, so we want to bring them into balance. And in order to do that, lithium is one of the best. We can use the sodium principles associated with the sodium potassium shifts that are associated with the anticonvulsants in the brain. Anyway, we want to make sure the dosage is adequate for the adequate time at the lowest dose. You don't want to overdose somebody. We do need to taper or keep lower doses for older adults so we don't have a rebound. Follow-up care is very important, and then keep it simple. If you have somebody who comes to you, I had a guy in Dayton, he'd come to me once a month for coffee, donuts, and his Invega shot. He lived under a bridge, but he came to see me every month. I think it was for the coffee and donuts. I got the benefit of keeping his psychopathy in control with his Invega shot, but the inducement was his motivation, I'm sure. Antipsychotics, that's on the table, chapter 2.3, conventional first generation. There's a whole plethora of them here. Chlorpromethazine, fluphenazine, thiourea. I wrap my mouth around these words just like you do. So haloperidol and loxapine, those are first generation. More chances of getting extrapyramidal symptoms with them. They primarily treat the positive symptoms of schizophrenia, not the negative symptoms of schizophrenia. Then the atypicals or second generation, clozapine, risperidol, olanzapine, Seroquel, Zyprexa, Risperidol. They treat the positive and the negative symptoms of schizophrenia or psychosis. And then the third generations are more dopamine stabilization, so epiprazole or Abilify. That's the one that you see sometimes added to antidepressants to increase mood. So it's an off-label use, but that's sometimes what they do. Mainly, antipsychotics are for treatments of psychosis. They block dopamine receptors. In some cases, you see an overabundance or not enough dopamine, and then you have some that are dopamine enhancers. Those are a little more particular. I'm not going to ask you the difference between them as far as do they block dopamine or enhance it, but I will ask you the difference between first, second, and third. Or it's a potential that I would ask you the difference. But again, I'm not going to apply these until we get to that disease process. So you don't have to worry about these until we talk about schizophrenia, okay, or psychosis, which I think is chapter 16. EPS. This is a side effect of your antipsychotics. It's or acute dystonia, pseudoparkinsonianism, akathisia, and tardive dyskinesia is another big side effect. And it's not like that you develop these in an increasing order. It's not. They all can manifest independently of each other. Usually an acute dystonia, you're going to see the torticollis where they have they call it wry neck, where they're twisted out like this. That's torticollis. Usually you're going to give like diphenhydramine. Pseudoparkinsonism, they look like they have Parkinson's, but they don't. Akathisia is really a restlessness or a moving around. There's a video that I actually show you when we get into schizophrenia that shows you EPS. Nurses are the first ones to see it because the person comes into the emergency room. They don't know why their neck's doing this. And the doctor says, hey, let's give them some Benadryl. We give them some Benadryl. That comes back, they feel better. They were having an acute dystonic reaction or an EPS. And usually you'll find out they were taking some sort of antipsychotic, whether or not they knew they were taking an antipsychotic. Maybe they thought it was a Tylenol out of their wife's purse or whatever. Anyway, neuroleptic malignant syndrome is another bad one. Really high fever, high 20% mortality. So, 2 of 10 people will die from neuroleptic malignant syndrome. Horrible high fever, vital signs all over the place. Usually that's what kills them. And then tardive dyskinesia is permanent, irreversible. Anticholinergic side effects with the antipsychotics are something that all of those hold. So they dry you up. Or revision, dry mouth, constipation, urinary hesitancy, all of those, you get dried up. It's anticholinergic. Other side effects, increased prolactin. So you may see gynecomastia in men from taking this. Weight gain, Zyprexa, is the big one in the second generations that will cause metabolic syndrome or diabetes. Cardiovascular adverse events, including that prolongation of the QT interval. And then agranulocytosis with clozapine, which is a second generation antipsychotic. This would be a black box warning that you might see with Thorazine. You got to keep people on their meds. Antipsychosis is something that they're going to be on meds for life if they have a true schizophrenia or schizoaffective or schizotypical. They're going to be on meds for life. So they're going to be anticholinergic for life. That dry mouth, we can tell them use the sugar-free candy, drink lots of fluids to keep their, the bowels moving. They might be sleepy. Try not to, like Seroquel is what we call a sleeper. It's a second generation antipsychotic. So we give that one at nighttime instead of during the day. So all of these things you need to instruct your patient on so that they're safe. And then usually if it's within 4 hours of missing a dose, you can go ahead and give that medication. Okay, stop share screening here. And I'm going to pause you guys for a minute because somebody is trying to get my attention. Okay, so I'm back. I have a class here coming up in half an hour, and that was my teaching partner. So we still got time. All right, let's take a look. We were here, I think. Okay. Again, like I said, antipsychotics, this is going to be, am I sharing this screen? I don't know if I am. So let me just do this. We're going to in this show. And we're going to go back here. I'm going to go here. And I'm going to make sure I'm sharing. And this. I'm not sure what I'm doing here. Hang on. Okay. All right, and we go here. Move myself here. There. And we are way down here. Sorry, guys. Okay. There we go. Ha, okay. Um, yeah, basically talked about that. Which drug is classified as conventional or first generation? And I think yesterday we all determined it was fluphenazine, which it is conventional first generation antipsychotic. Depression. So antidepressants, there's a lot of them. Tricyclics, SNRIs, SSRIs, MAOs. We don't use MAOs too much anymore though because of the dietary restrictions. SSRIs and SNRIs are really first line for depression. And we'll talk about those later when we'll talk about depression. I mentioned there, we don't know. We don't know how they work. We just know that they do. Usually from imaging where we see activity in the normal brain, no activity in the depressed brain, and then activity again with the treated brain on the PET and the SPECT scans. Major interactions with the monoamine neurotransmitter system, especially norepinephrine and serotonin. SSRIs, some of the side effects, anxiety, agitation, akathisia. Prozac will make you gain weight. Tricyclics, very sedating. So we usually give tricyclics, amitriptyline, nortriptyline, things like that at nighttime. They're also anticholinergic, so they're going to dry you up and cause sexual dysfunction. MAOs, usually if you eat foods with tyramine, they can cause hypertensive crisis and you can have a stroke or die. It's really kind of a restrictive diet. So we don't use those too much anymore. If I have someone who comes into treatment, and they're on an MAOI, I'm not going to take them off of that. If they've been on it and they eat the same thing every day and that's their life and that's the way their life's been and they don't want to change things up, then why fix what's not broken? So, but it's not something you see a lot of the doctors use first line. And then we have others. So nefazodone and trazodone, Deserel, probably see that in long-term care is, again, it is a sleeper. So you're gonna see them taking that at night. Some of the other side effects, loss of appetite, agitation, that's bupropion and venlafaxine, Effexor and Wellbutrin. Causes people to have a lot of shaking. And then priapism does go with the trazodone. Serotonin syndrome, you see that a lot, and it can kill you when you have an MAO plus SSRI, or if you have SSRI being used when you don't need to be using an SSRI. It's an overabundance of serotonin, and it can kill you. There's also serotonin discontinuation syndrome. This is when you stop an SSRI or SNRI abruptly and you don't taper it down. These are the class of drugs you really want to taper. But I don't want to get into too much of that until we get into depression. Timing of dosing. SSRI should be in the morning. They keep you awake. SNRIs should be in the morning. Cyclic compounds, I mentioned before, there are sedating, so use at night. The antipsychotics, if it's within 4 hours, you can take the dose. If you've missed it, up to 8 hours for SSRIs, and the tricyclics within 3 hours, or you got to completely just forget the dose for that day. And just be very safe with them. The dietary restrictions, I mentioned those with MAOIs. You can see those in box 2.1 in your text, or you can just remember it's kind of everything you like to eat. Wine, cheese, Chinese food, chocolate, anything fermented, anything aged. You can't eat it on an MAOI. It'll cause a hypertensive crisis. Mood stabilizers, there's lithium and there's anticonvulsants. Usually the anticonvulsants, again, off-label use primarily in pregnancy or lithium. Although some doctors these days are starting to use the anticonvulsants instead of lithium just because it can become toxic and you have extensive blood work that you have to do with lithium, and because it has therapeutic levels, you have to maintain those therapeutic levels. Um, Lithium normalizes certain neurotransmitters, mainly the ones that have to do with salt movement in the brain, salt and water. Valproic acid and topramate increase levels of GABA. And if you remember, that is an inhibitory neurotransmitter, so it calms people down. And then valproic acid and carbamazepine inhibit the kindling process of the building of the neurotransmitters. Lithium, really, really something, good drug, came out in the 50s, very toxic because of the neurotherapeutic index. You can get sick really quick. If you have diarrhea, any kind of dehydration, you got to call your doctor. You really can't take the lithium. Nausea, vomiting, it causes nausea and vomiting, anorexia. The big key with lithium, they're taking their meds if they have fine hand tremors. That is something that happens every time. And it does go away, but it takes a while. And then with toxicity, it can kill you. It's bad stuff. You can kill your kidneys and, you know, 19, 20 years on lithium, you might need a change just because your serum creatinine will start to do weird things. And yeah, you can go into kidney failure. So carbapazamine, bamapazamine, I can't even say these, gosh, carbamazepine, valproic acid, it causes drowsiness and sedation, those anticholinergic effects. Side effects, some of the specific ones, the valproic acid does cause hand tremors and alopecia. Tiraprimate causes dizziness. I'm not going to ask you specifics, and if I want to know specifics, I will let you know which drug you need to know. Okay. Lithium, usually 12 hours after the last dose taken to get your therapeutic levels. And then take a lot of these medications with meals. And just remember, if you're giving an anticonvulsant, it can cause a convulsion, so you can't have seizure. So, and a client who takes an SSRI and MAOI is at risk for hypertensive crisis, and that is not true. SSRIs and MAOIs cause serotonin syndrome. But if you do MAOIs and tyramine foods, you can have a hypertensive crisis. So it is false. Anti-anxieties, used for anxiety and anxiety-like disorders, insomnia, OCD, depression, PTSD, alcohol withdrawal, and that is benzodiazepines and bupropion. So the benzodiazepines, Librium is one that comes to mind. There's a few others. They mediate GABA. And then we get some partial serotonin receptor agonist activity with Buspar or buspirion. The bad thing about benzos is that they cause dependence, physical dependence, psychological dependence. They can build a tolerance, or you're using more and more and more of it, and can have that hangover effect. Not so much with Buspar. It's not as addicting. It does cause some dizziness and sedation, but like I said, you don't build tolerance with it. You're not hungover after you use that. Some people find the nausea, though, and the headaches bordering on migraine to be something that they don't want, and they won't use this drug because of it. So we want them to be as safe as possible. So we don't want them drinking alcohol. Alcohol is also a depressant. It's not a good idea. And we don't want them to stop using it abruptly, because with those benzodiazepines, they're going to go through withdrawal. Stimulants. Amphetamines, dextroamphetamine, methyl, I called it methamphetamine yesterday, but it's methylphenidate. Those are all amphetamines or stimulants. We do use them therapeutically for ADHD. And let's see, narcolepsy. They release epinephrine. Norepinephrine dopamine is serotonin presynaptically, and they block the reuptake. So we have those neurotransmitters lingering in the synapse longer. We give them in divided doses for narcolepsy, and doses for treating ADHD are just, they're all over the place. The big thing with kids in ADHD and using stimulants is you got to watch their weight, causes extreme weight gain or weight loss. I'm sorry, especially if they're allowed to maintain a diet that has caffeine, or a diet that has any other kind of stimulant in it. Um, Side effects, anorexia, weight loss, nausea, irritability. It can cause growth suppression. Um, it's not as severe as smoking and coffee, whatever, but it can cause some growth suppression. So a lot of times dosing for kids especially should be after meals, and we want to keep them away from all the caffeine producing foods and keep it out of reach of kids, because a lot of college students, not saying our college students here, but a lot of college students in the big universities, the literature is showing that they're using them to stay up at night to study, things like that. Disulfiram and abuse, disulfiram. It's aversion for alcoholism, so it makes you really sick if you have alcohol. It interferes with alcohol metabolism. So side effects, halitosis, drowsiness, tremor, and impotence. But those are not the effects if you drink alcohol while you're on this drug. Use mouthwash while you're on this drug. It can make you violently ill, nausea, vomiting, diarrhea. It's really bad stuff. So they have to stay away from alcohol with this drug. It also has interactions with dilantin or phenytoin, isoniazid, warfarin, barbiturates, and benzodiazepines. So they have to stay away from alcohol and including products that contain it. Like what I'm saying is mouthwash because it has alcohol in it, like Listerine and things like that. But they say shaving cream, deodorants, over-the-counter cough preparations. I have not heard of a case of somebody using something topical like shaving cream or deodorant having this kind of an effect. But this is what your book is saying. So over-the-counter cough preparations oftentimes do have an alcohol in it. So you don't, Robitussin, we don't want them using that when they're using Antabuse or disulfiram. So which drug would the nurse expect to administer to a client with ADHD? Well, we know disulfiram is with alcohol, and we know Boost Bar's anxiety. We know lithium is mood. So it has to be the middle one, methylphenidate. Yay. Genetic considerations, again, a lot of these disease processes, schizophrenia, mood disorders, they're genetic. So you can't make an assumption based on race or ethnicity and say, oh gosh, they're German. They're going to be drinking beer and, blah, blah, blah. You can't do that. You just got to look at the genetic components and then ask the patient about their personal experiences or past experiences if they've ever used these drugs before, or if they've known somebody who's used these drugs before, because sometimes people can have expectations that they create in their brain from seeing something that their mom or dad used. So you always want to ask those questions. And remember, it's genetics. We have to be careful with herbal use, and you need to ask them, do you use any herbs? St. John's wort, that's an antidepressant herb. It can interact with just about every antidepressant we got. We have kava, we have valerian. Some people use those for mood. Ginkgo sometimes is used for anxiety. Those things all interact with those classes of drugs we just talked about. So got to be real careful with those. And then you got to be aware of yourself. Again, if you can't deal with mental illness, um, you have to stay open to it. You have to be willing to understand that mental illness is just like physical illness. It can have moments of exacerbations and it can have moments of remission. And, somebody with diabetes can be out of control with their blood sugar and they can be in control with their blood sugar. But that stigma of mental illness makes us all want to kind of shy away from that, thinking that we can cure diabetes or we can cure cancer. And really, no, the best we can do for chronic diseases like that is put them in remission. Mental health is another chronic disease that you can put into remission. Okay. And that is chapter 2. So, if I get done here, let's stop sharing my screen. If I get my class done here, which I should be able to get it Yeah, we're like 12 to 4. So I'll come back and I'll record chapters 3 and 4, so that you can review those for next week before you come to class. And then I'll ask, in class, I'll say, do you guys have any questions about chapters 3 and 4? We'll talk about chapters 3 and 4. Again, there is no quiz next week, so don't be don't be scared. And we'll just review chapters 3 and 4. And then again, the lecture should be up for you to go back and forth with. If you have questions, bring them to class. We'll talk about them first, and then we'll launch it to the lecture. The week after that, you do have your first quiz coming up. I will have chapters 5, 6, and 7 recorded previous to class. You'll be able to review that previous to class, the lecture, come to class with questions. I can answer the questions. We'll get as far as we can. In the material, it's probably to your benefit to review the material before you come to class. That way you kind of have heard it twice when you get there, at least portions of it, for the quiz. And then we'll have our first 25-point quiz in 2 weeks. So, I'm excited. This is going to be good. And hopefully I'll change the background next time. I was just thinking of the beach today. And if you guys are thinking of any other backgrounds you'd like to see, let me know. I'll put them up and we can, kind of have a little fun with that too. I'll see you next time. Enjoy your weekend. I'll see you Tuesday.